Morning, everybody, and welcome to our 2025 kickoff of Quality Leader Session. We are so excited that you've joined us, and we're excited about what this year is going to bring for all of us. We have our chat going, so feel free if you have any questions or comments, please feel free to jump in the chat and we'll keep the conversation going. At the end of the session, we have a short survey that we would love for your feedback on. And any thoughts that you have on additional trainings for the year would be helpful for us as we look to serve your needs and what's important to you. It is my honor and privilege to introduce our speaker today, Sarah Couture. Sarah Couture leads the Couture consulting line and is a corporate compliance specialist. We're excited to have her here with the new updates that we see OIG releasing for the post-acute industry last November. So without further ado, we'll hand it over to Sarah. And looking forward to your information today. Thank you.
Thank you, Alyssa, and appreciate the invitation to share. It was nice to have a little bit of discussion beforehand, just so that I kind of know, a lot of the folks in the audience obviously are here for the nursing facility focus, but certainly, the components like Patricia was talking about, there's some overlap and there's some tie-ins. So one of the things we're going to do today is talk about the different guidance documents that are out there, just so that people kind of understand, what goes with what. I do think it would be great to have interactions. So if people are interested in, typing a chat or, even just jump in, this is not a huge group. So feel free to jump in, turn off or, unmute yourself. If you want to make a comment or a question, I think that actually makes these discussions a lot more interesting. So feel free to do that and let's go ahead and jump in. Like Alyssa mentioned, my name's Sarah Couture. I'm the principal of Couture Consulting. I'm a nurse by background, who accidentally fell into compliance about 15 years ago. We probably all can say that about what we're doing right now. Like we probably didn't plan to do what we're doing right now, which is something that I share with my kids. Like, hey, don't worry about it. Life's gonna take you down roads you don't plan, and that's part of the fun. So I didn't really even know what compliance was as a bedside nurse in a variety of settings. I actually was a CNA at a nursing home before I became a nurse, and have stayed relatively closely tied to the skilled nursing industry, especially in the 2015-2016 era, when the new requirements of participation came out, requiring a compliance and ethics program. So I've done some work with ACA and some state associations around education, as well as when PDPM came out and some of the compliance implications there. So really what I consider myself, though, is a compliance expert in the provider space. So really anyone who's providing services and billing for them. Some of the settings that Patricia mentioned, I've worked a lot with a lot of IRFs. I work with a lot of hospitals and health systems. I work with physician practice groups. I work with DME. Whoever is providing services and billing has compliance needs. So if your questions today are specific to skilled nursing, great. If they're a little bit outside of that, but around general compliance, that's great as well. We can cover all of those things. So like I said, a nurse for 25 years. I also teach and speak a lot. I'm faculty for the Healthcare Compliance Association Compliance Essentials Workshops, as well as the Research Compliance Academy. I know that ACA and Leading Age have a lot of resources available around compliance, but some of you may not be familiar with the Healthcare Compliance Association because it is regardless of your provider type. So if you hear this conversation and you're like, oh gosh, I want to be a compliance nerd like Sarah because it's so exciting, would love to help you get connected to the Healthcare Compliance Association. I'm happy to chat about it. I think my email is here at the end, so would love to connect further.
Sarah.
Yeah.
I just have to say, you are so blessed with that last name because the name of your firm is so interesting.
Well, thank you.
I love that.
I appreciate that, Anne Louise. When you develop a name for your firm, I didn't know that I wanted to have my name in it, but my marketing consultant was like, you kind of have to because
absolutely. Yeah.
So, yeah. There. Thanks for the comment. Appreciate that. So before we kind of get into the specifics around the new, as in November, industry specific, the ICPG for nursing facilities, I want us to go back in time a little bit. We're not going back in time very far because, as you may or may not know, compliance is relatively new. Compliance professionals were not really a thing before the 90s. So really, I mean, the founders of the compliance profession started, like, we're talking late 90s, 1996, 1997, 1998, when all of a sudden we were having more concerns around fraud, waste, and abuse. There were the big compliance fiascos, like in the telecom space. We see the federal sentencing guidelines come out with compliance guidance, and all of a sudden healthcare, thank you OIG, gives us in the late 90s our first compliance program guidance. So tons of my friends in this space have fascinating stories where, you know, their CEO came to them and they were an administrator or a nurse or a director of whatever. And they were like, hey, you want to help us figure out this thing called compliance? So it's great because it's new. It's also really interesting because the people who are compliance professionals tend to have a variety of backgrounds. Patricia mentioned she's a dietitian. I know dietitians who are compliance officers. We come from operations, we come from audit. A lot of us have a legal background, a lot of us have a clinical background. So it's a very rich group of people who tend to be drawn here. So a lot of people in healthcare operations get confused about what in the heck is compliance. Like, I hear people say it, but as an action, compliance is being compliant with whatever regulations apply, right? So all of us are concerned with whatever regulations apply to either our clients or our organization, because we need to know what rules apply to us and we need to follow the rules. That's being compliant. A compliance department or a compliance program, if you look at this definition here at the top, is a distinct department that, as a tool of leadership, helps provide oversight to the organization to help look for areas of risk and help the organization adhere to legal, ethical, and professional standards. The standard in compliance is literally the word effectiveness. If you look at Chapter 8 of the Federal Sentencing Guidelines, which many of you may have not, but it's a thrilling read if you're ever interested, it talks about if you have a compliance program that effectively prevents and detects fraud, waste, and abuse, you can actually decrease your penalties in cases of corporate wrongdoing. So there are actual stories out there where something went terribly off the rails, but the compliance program was able to evidence that it had done everything it could do. It had all of the 7 elements that we'll talk about, and it was actually working. So that organization didn't have to pay any penalties. So a compliance program is protective in kind of that general sense. We're going to talk specifically in a minute about how the 2016 requirements of participation changed that, or didn't change it, added to that specifically in nursing facilities. But right now we're kind of talking generally. When we think about a compliance program, you know, people are also like, all right, so we have a compliance program. What risks do they care about when it comes to regulations? We tend to care about fraud, waste, and abuse risks. So think about the regulations that are involved where we have a risk that there could be fraud or waste of federal dollars or abuse of federal or state regulations. So the laws we typically think of are things like the False Claims Act. When you read in the news or look at enforcement actions on OIG's website, and let me say, if you're not familiar that OIG publishes not all, but a lot of the enforcement actions in the healthcare fraud, waste, and abuse space, they do. And they're like fascinating reads. It's like real life soap opera when you read about these schemes that people have done. And obviously, a lot of them are schemes, but sometimes it's people that just didn't know what the rules were, which is a whole other conversation, right? So when people have billing issues, like they're billing for services that were never provided, or they're billing for a higher level of care than was provided, or as we've seen a lot, I shouldn't say a lot, but more in the skilled nursing industry than in other areas, is billing for services that were of such poor quality that the government says they should not have been billed at all, or worthless services. That's a False Claims Act. That's the regulation there. So billing and quality are tied into the False Claims Act. We also have anti-kickback and Stark, which are related to our relationships. We know that we shouldn't take kickbacks from vendors, or like we shouldn't be paying hospitals money because we want them to refer their patients to us. Like those sorts of things are illegal. The regulation there is the anti-kickback statute. Stark law is related to physicians that have ownership interest. So, all of these have implications in nursing facilities, obviously. The government also has the ability to exclude, and there's these civil monetary penalties around it. There's beneficiary inducement. So in our relationships with hospitals, we know that they're not allowed to steer patients, right? So inducing benefits or steering, there's regulations there, HIPAA privacy, the list goes on. These are really the main ones when we think of fraud, waste, and abuse. So we talked about why it's important. It can literally save our organizations thousands or hundreds of thousands of dollars. So leaders, boards, CEOs should be super excited about compliance. But as you can imagine, not everybody's super excited about compliance. They feel like it's a roadblock instead of feeling like it's a partner that can help us provide better quality of care and also keep our butts out of hot water, which is the goal. So when we talk about the history, I said it's late 90s, but we saw just the first corporate integrity agreement was 1994. The first OIG, which is Health and Human Services Office of Inspector General Compliance Program Guidance, came out in 1998. It was the first snapshot we had of, all right, what in the heck is a compliance program? What are we supposed to be doing? Very shortly thereafter, in March of 2000, we saw the first compliance program guidance specifically for nursing facilities. So what that did was kind of take those concepts of compliance that we're going to talk about and apply them to the specific risk areas, fraud, waste, and abuse risk areas that we see in skilled nursing. And then in September of 2008, they came up with a supplement to that guidance. Alyssa, you came off mute. Do you have a comment?
I think everybody knows this, but it might be helpful to talk about what OIG's role is in compliance and what a corporate integrity agreement is. I remember hearing about them in conferences and hearing about them being talked about, but sometimes I think more about how survey comes through at CMS. And so how do these pieces link together?
Yeah, perfect. And we'll get to how they link together, but you're right. I should have talked about the acronyms. So OIG is part of Health and Human Services. It's kind of the watchdog organization. I chuckled this week when we got an OIG announcement that they looked at FDA's like fast track, and like a certain number of the drugs they felt like FDA had not followed their own policies to fast track a drug. Like scary, right? But OIG is the watchdog. So what OIG is doing in the healthcare compliance space, including in nursing facilities, they're the watchdog to make sure that the government is spending its money in the right ways. So how that applies to all of us is that we're accepting government money when we take care of patients, right? When we accept Medicare, Medicaid, TRICARE, et cetera. A CIA is a corporate integrity agreement. And essentially, if you get in trouble with the government, they can exclude you from participating in Medicare and Medicaid, as in you can no longer accept those. Or another option, again, this is all very dependent on the situation, but you can settle with the government. You can sign up for a corporate integrity agreement, which is a government settlement. They are 3 to 5 years long. And essentially, in exchange for settling, you agree to all these terms to beef up your processes. They're all about compliance. So again, on OIG's website, you can go read corporate integrity agreements and read what other facilities and other institutions have had to do because they've gotten in trouble. They also are very expensive, and they always come with hundreds of thousands of dollars worth of fines. So we then had the Affordable Care Act, which said, mandated compliance. Now, interestingly, that actually hasn't been implemented yet. So when we talk about voluntary versus mandatory in a minute, in October of 2016, as you all know, CMS, not OIG, we've been talking about OIG. CMS updated the long-term care requirements of participation. And lucky nursing facility industry, you were the first and only to have a compliance program. Everybody else, it's voluntary. Now, it's stupid if you don't have one, right? So everybody does, but you all have to. And as you know, you're surveyed against it. So one of the things we're going to talk about is checking the box of the survey, kind of compare and contrast to that effectiveness that we talked about, because that's what gets you out of hot water federally. If you can say we're working to effectively prevent and detect fraud, waste, and abuse, that's a little bit different though than the checklist, right, that the surveyors look at. So there's a typo here. It was actually November of 2023. OIG came out with new, it applies to everybody healthcare, general compliance program guidance. It's linked in here and we're going to talk about it. And then, as you know, this past fall, and that's what we're talking about more today, is OIG came out with the industry specific compliance program guidance for nursing facilities. Nursing facilities are the first, but other areas in healthcare are going to get their own ICPG, Industry Compliance Program guidance as well. Managed care and labs are up next. Hospital is going to be after that, and we'll see them continue to roll out. I think this is a very helpful tool to kind of think about, all right, so everybody has to be compliant. What is the compliance program? So this is actually this is called the third line of defense. It's an internal audit concept, but essentially if your organization has put such good controls in place, and when I say controls, it's people who understand their risk, leaders who have the right policies and procedures, put the right education and training in place, leaders who are monitoring risk areas, right? If you have all of that rolling and your frontline staff, they are your best defense to be compliant because we've given them what they need to be compliant. But we know that in the real world, we also kind of do need the lifeguard of the pool. So we have things like internal audit and compliance as our third line of defense. We can't look at everything, but we look at the highest risk areas to help the organization know where there are control gaps in that first line and second line. That's really ideally how it should work so that everybody knows how to follow the rules. I love this graphic. I have to give kudos to our friend here at Constellation, Scott Wilson, who made it. I could not have come up with something this cool, but I'm like, Scott, I need a slide that kind of shows this lifeguard of the pool concept. I mean, he literally delivered when he gave me a lifeguard of the pool illustration. But I really like this because think about all these areas you see here: quality, marketing, finance, our medical records department. We need these departments to be operating compliantly. Corporate compliance as a department exists outside of all of that independently to kind of look at risk and help leadership know, are there areas that we need to beef up, that need to be stronger so we don't get in trouble? So I think this is a helpful graphic. If you've been confused about what in the heck is compliance, I think this is a helpful concept. So why should we even have a compliance program? Well, it's required if you're a nursing facility, but there's a lot of other reasons as well. It protects and promotes quality of care. Like we know this, but it's nice to remind ourselves. And you know, some organizations, leaders are actually resistant to compliance because they feel like it's a roadblock. So sometimes it's nice to remind them. It helps protect our organization's reputation. There's nothing worse than being front page news in healthcare. We know that. I worked with an organization that got in trouble over cardiac devices and medical necessity. It took them 4 years after they signed their corporate integrity agreement to go from losing money every year back to making money again. It increases staff engagement and awareness of doing the right thing or who to call if they have a suspicion that something, may be questionable. Like we talked about, it can decrease culpability and decrease penalties and decrease fees and maybe help us avoid a corporate integrity agreement because they are very onerous. What are the risks of being non-compliant? It's kind of the opposite side of that coin. You can lose money, legal costs, reputational damage, legal challenges. Exclusion from Medicare and Medicaid is a real risk. And a lot of organizations don't have enough private payers that they could actually stay afloat without federal dollars. Erosion of staff morale. We've all seen or heard of organizations with toxic cultures where terrible things happen. Compliance can help with that. Other losses. So I think this is a helpful concept that we're going to take a minute to talk about. You may or may not have been familiar with the guidance that came out from OIG. Again, we're talking federal right now. We're not talking about CMS requirements of participation for a minute. We're going to pull those together in a second. You may have been familiar with the 2000 and the 2008 guidance, or you may not have been. But in 2023, we got the new general compliance program guidance, which applies to everybody in healthcare, including life sciences and pharmaceutical and things like that, everyone. And then in 2024 in November, we got the first industry-specific compliance guidance. The links are here at the bottom. So if you haven't checked out these documents and you're interested in compliance, these are good spots to start. Let me say that do not read the ICPG for nursing facilities without starting with the general compliance program guidance. The nursing facility compliance guidance is like an amendment or like an addendum to the general compliance program guidance. The general compliance program guidance are things that are guidance for all of us. It gives much more detail on the laws that we're talking about, what a compliance program should look like, how to get it right. Then the ICPG really talks a lot about the specific risks in nursing facilities. So let me encourage you to not read these documents in isolation, look at them together. Now, thinking about the interplay of our requirements here, and Alyssa mentioned that early on, we know that we have the CMS requirements of participation, that if we want to be participating in taking care of patients in nursing facilities, we must have a compliance program. It's linked here for you. I'm sure that we're all very familiar with that document from 2016. And it is mandatory guidance. It's not like, oh, if you want to, it's mandatory. Then we have the OIG guidance, which is what we just talked about and what we're talking about today, the new ICPG. It even points out in its intro, it is voluntary guidance, and it acknowledges that the CMS requirements of participation are mandatory, but this voluntary guidance is to help kind of flesh out and supplement and make more effective the compliance programs that are in place. We also have, for those of you who really want to geek out with me, an additional guidance documents from Department of Justice, which is not healthcare specific. It's for everyone, for all types of organizations. And it is guidance on compliance program effectiveness. That's an interesting one because it's actually guidance that's written to Department of Justice investigators, advising them how to evaluate whether a compliance program is effective or not. So essentially that's kind of the answers to the test. So if you want to read through that one and think about your own compliance program, you can give yourself a grade, or you can maybe say, oh, we might need some help here. So let me pause. Does anyone have any questions about CMS, the requirements of participation, and what the compliance program have to look like are mandatory? And then we have OIG guidance that we're talking about today that is voluntary, but helps us have a more effective compliance program. Is that confusing or is that clear? All right, must be clear. Okay. So,
and Sarah, I've been dropping the links from the slides into the chat. So all of your links are in there for anyone to reference.
Great, perfect. So when we talk about compliance, there are 7 elements of a compliance program. And if you're not familiar with compliance, none of these are going to surprise you, but these kind of provide what I like to think about the skeleton, because every compliance program is going to look different, but at its core, the skeleton, they all look like this. Every compliance program has to have written policies and procedures, including a code of conduct. Every compliance program has to have the right kind of leadership and oversight. That includes not just the chief compliance officer, but also senior leaders being engaged and the board understanding their oversight responsibility relative to compliance. Every compliance program has to have training and education, right? Makes sense. We all have to have effective lines of communication, including when it says disclosure program. What that means is a hotline, essentially. And it's an anonymous hotline. And I always recommend outsource it. They're cheap, and that way they're actually anonymous. I can't tell you how many people I've bumped into that's like, oh, it's anonymous, and it's my answering machine right here on my desk where I can hear people's voices. And hard to say that would be anonymous. But a way that people can report without being scared to report. If they can report anonymously, you theoretically could get more reports and also prevent something called a whistleblower risk. We've probably all heard that. We don't want our people to be whistleblowers. We want them to come to us with their issues, and then we have to listen to them and investigate and address the issue if we find something. Another element, enforcing standards. You can have all the rules you want, but if you don't enforce the rules, what's the point? So what are the consequences around the rules that you've put in place? And also, how are you incentivizing compliance? What do you do to encourage people to be compliant? Another element is risk assessment, auditing, and monitoring. And we're going to talk about risk assessment a lot more as we go forward, because really, when I talk about the skeleton being the 7 elements, you build the rest of the body around that skeleton based on your specific risks. So in nursing facilities, we know what our risks are, and we're going to talk about those today from the industry specific guidance, but that's kind of how you build it out. That's how you know what policies to have. That's how you know what to do your education about. That's how you know where to be auditing, because you understand what your compliance risks are. And then the final element of a compliance program is responding to detected offensive and developing corrective action initiatives. If you find something that went off the rails, you can't just leave it alone. You have to actually do something to fix it. And then you should come back and make sure that whatever you did is actually working to continue to mitigate that risk. Here's just a snapshot of what the specific requirements are from the long-term care requirements of participation. I could have actually put these kind of side by side. You'll see that, like, while it may be in a different order than what we just saw, which is from the general compliance program guidance, the same things are there. You got to have written policies. You have to have high-level program oversight. This talks about a screening process and resources as well, effective communication, procedures to promote compliance like auditing in an anonymous reporting system, consistent enforcement, appropriate response to violations. It actually includes, which I think is super good, an annual review and update of the compliance and ethics program. I spoke, like I mentioned, when the requirements of participation first came out, I spoke for several years in a row at ACA, just helping people get ready for this. And this gentleman said, oh yeah, we have a compliance program. It's in a binder in my office, and I don't think anybody's taken it off the shelf since the 90s. That's not an effective compliance program. So it's a good idea to have a process that annually we look at it and we update it. How do we need to make it better? And then, as you are already aware, organizations with five or more facilities have some additional requirements, including annual mandatory compliance training, appointment of a compliance officer, and a compliance liaison at each facility. These very much look like those 7 elements, but these are a little bit more specific to nursing facilities from the requirements of participation.
Sarah, do you recommend that we bring this into our QAPI process and have it as an agenda on our QAPI meetings, our quality assurance process improvement meetings?
You know, a lot of organizations have taken this requirement, and compliance and quality and QAPI are all kind of in concert. You know, you don't have to start from scratch, right? You have a lot of these processes and conversations in place already. So Alyssa, essentially taking something like your QAPI process in those meetings and adding these concepts to it that we're missing is a great way. You already have the right people at the table. Essentially, you're just kind of widening the purview and the risk discussion of that group. But yeah, that's a perfect example of, like, how do we not break our backs and still be compliant? Like, how can we take what's already in place and make some edits and leverage? Even things like compliance liaisons. You don't have to hire someone. You need to figure out what's the most practical person to do this. How do we train them? How do we engage them? So a lot of it is pragmatism, but obviously, Alyssa, I think a lot of people in the beginning were really nervous about this because they didn't know what to do. But I think what you just mentioned, like taking things that are already in place and making them work to be compliant, is a great approach. I mentioned this already, but you know, this just kind of helps us see how these documents go together, because the OIG General Compliance Program Guidance is applicable to all of the healthcare industry. It talks about what is a compliance program and what should it look like in great detail, as well as what laws apply and how to structure a compliance program. Like I mentioned, think of the nursing facility ICPG as a supplement to that. It adds on. It talks about the specific compliance risks and mitigation in skilled nursing facilities. It has some other considerations as well, but like, they can't be read in isolation. If someone thinks they only need to look at the nursing facility, they're going to actually miss the meat of what a compliance program is, what laws we're talking about, etc. So we're going to spend a few minutes, and these slides, I will say, have a lot of details. So I know Alyssa mentioned this will be on YouTube. I don't know also, Alyssa, if you PDF the slides so that they're there and downloadable or whatever. So I'm not going to like read every word, because you're going to be like, dang, Sarah, you put a lot of words on these slides. But I wanted to pull out the specific compliance risk areas that are mentioned in the ICPG, because these are the ones that you, like I mentioned, you take those elements, the policies, the education, the auditing, and it's of these risk areas. So these risk areas inform what our compliance program should look like in a nursing facility. And the guidance also gives recommended mitigation actions. Let me say, it is not all inclusive. These are the common risks. So it's important that organizations have their own approach to compliance risk assessment or enterprise risk assessment that has a significant compliance component, because there may be some really specific things in your organization or something that's going on like in your region that is a risk and it's not listed here. So don't assume like, okay, great, we've got all the answers here. Like, be smart. These are suggestions, these are common risks, but this is not all inclusive. Okay, bucket one. It's the most important to all of us, right? It's why all of us are in healthcare. It's quality of care and quality of life for residents. So it's not just important clinically, it's not just important administratively, it's not just important personally to us, but it's actually important from a compliance perspective. And like we've seen in enforcement, you can get in really big trouble and pay a lot of money back or get shut down, obviously, right? But if you are not doing what you need to do around quality of care and quality of life, and I know Alyssa and the team here at Constellation are, the best in the country at these issues, like helping organizations make sure that they have what they need and they have the processes in place to make sure that patients are safe and also that they have a good quality of life and that regulations are being followed. We know that failing to meet the standards could be violations of the ROPs, but they actually could also be false claims. So this is kind of where where CMS and OIG guidance kind of bounce into each other, right? If you fail to meet the standards, you could get in trouble with CMS, but you could also get in trouble from like the OIG federal perspective, because they could say, this wasn't just one false claim. These were multiple false claims. You had a culture of doing this wrong, or people reported it and you didn't fix it, or your audits identified it and you did nothing, or you failed to audit. So things can become a lot bigger quickly when you have kind of the merging of these two perspectives. Your compliance professionals, now I don't mean the compliance liaison, right? Because of the compliance liaison at each location, it's probably wearing multiple hats unless it's a, enormous facility. So your compliance liaison may be a clinical quality person, but at the corporate level and compliance at its core, compliance should not be making decisions, right? But compliance needs to collaborate with the right leaders to make sure that appropriate controls are in place to protect residents. So a few risks we wanted to highlight here. These are not anything that surprised you. You guys actually I could probably mute my mic and you guys could all jump in and present these slides because these are the realities of every single day. But it's not just from a CMS perspective, it's also from an OIG perspective that these are risk areas. Staffing level shortages and staff competency. We talk a lot about workforce and staffing and having teams that are prepared. Like, that is one of our best defenses to quality of care issues, having the right staff, making sure that they're trained well, managed. Now, I know actually finding people and keeping the levels is a whole other story. I'm sure that this monthly call has had other people talk about solutions there. Another highlighted risk, appropriate resident care plans and resident activities. These, again, we see requirements of participation speaking to this, as well as the OIG compliance guidance. Challenges due to demographic changes in resident profile, higher resident acuity, and behavioral health issues. These are not easy things to manage, right? These are things, again, that are on our minds all the time, but really need to be from a risk perspective to fulfill our regulatory obligations and ensure quality of care and quality of life for our patients, our residents. The other highlighted risk in this section, medication management. A pharmacist has to be available to consult with and has to review monthly the residents' medications. And it's a great idea to leverage that pharmacist in other ways, like providing staff education. Appropriate use of medications is another one. When you look back, on your weekend reading, when you have nothing else to do and you're reading all these great guidance links that Alyssa put in the chat, you'll see from both the 2000 and the 2008, you'll be like, oh, wow, they've been talking about this for a long time. Yep. Like, these are most of the similar or same risks that we were talking about 24 years ago in 2000. Oh my gosh, 25 years ago in 2000 and in 2008. Things look different now because we have different technology and, regulations have evolved. But really the crux of, our concerns in this space, all of us, I don't mean our as in the government, I'm not the government, like our collective concerns as an industry continue to be the same. And then resident safety, abuse and neglect, screening staff appropriately, emergency preparedness, infection control, etc. All of these, even though they're quality of care risks, and even though they're in even some of our accreditation, they're also compliance risks where we have regulations that we have to follow, and these items can get us into trouble in kind of a fresh way than maybe what we would have thought about before. The second bucket, Medicare and Medicaid billing requirements. There's a slide later in the deck that will have a link for you. But I do want to point out that within the ICPG, it actually references and has a link to a supplement, another 12 pages for you, that unpacks some of these Medicare and Medicaid billing risks. I'm a nurse, like I mentioned, so if I would have not fallen into compliance, I would have been like this right now, like, oh, let's not talk about billing. I don't want to talk about it. But it's good for us as clinicians to understand the billing regulations and our role in them and how things can go awry. You may actually think it's interesting if you haven't started digging in here a little bit. But it's important to make sure the right policies and procedures are in place, the right controls to make sure that the bills are accurate. Obviously training staff, and then doing auditing and monitoring. I think a good question, if you're like, I want some takeaways from this presentation, I'll give you some more at the end, but I think a good takeaway would be to go back to your facility and understand whether that's with compliance or whether that's with your compliance and QAPI kind of collaboration. Where are we doing auditing and monitoring? Is it in the right places? How do we know we're auditing and monitoring in the right places? What are we doing with our findings? Do we have a plan? I think that would be a really good kind of takeaway. It'll help you understand, but also you may uncover an opportunity just to continue to develop controls for your organization. Federal.
Sarah, we have a question.
Yeah.
Are there available resources that combine the regs from both regulatory bodies? And I'm thinking it's CMS and OIG.
Yes, and I mean, really, they reference one another. So, the requirements of participation, this is how a good way to look at it, I think. The requirements of participation are like what we have to do. And then, I know Stephanie that's on the call and Beth and Alyssa, like, you all know a lot of the specific regulations way in more detail than I do. Like, think of OIG as like helping us identify like the high risk areas and what we need to do around them. In many ways, it's the same regulations, right? Like our requirements of participation are what we need to do. OIG regulations are more around that fraud, waste, and abuse. So like, I don't imagine there's a whole lot of talk in like, when you're implementing quality and clinical things, nobody's thinking about anti-kickback statute, right? So that's kind of an overlay that you may see in the OIG guidance that like maybe just wasn't on your radar, making sure that like there's fair market value when we're paying for services, making sure that there's an approval process before we engage with whomever. Who's reviewing that? Is there a legal team? Because there have been and probably continue to be residents being referred for things that can trigger anti-kickback concerns. So I think that's probably a good example, Alyssa, where like if we're just focusing on requirements of participation, that kind of fraud risk isn't going to be in our head, right? So no, I mean, it's possible that Leading Age or ACA or someone has put out kind of like a combined document that I'm not aware of. But otherwise, it's just kind of being aware of like, the requirements of participation are what we need to do to take care of patients, but we need to be aware of these fraud regulations and waste regulations kind of peripherally.
Okay, that makes sense. There was a question if we're going to share the slides, and we will share the slides with all participants afterwards. Good questions, keep them coming.
Yeah. So I think, AKS, anti-kickback statute, is a really good example of some, like these other ones we were talking about. You're like, oh yeah, I know we need to bill right. Oh yeah, we definitely know about medication management and abuse and neglect and screening our people. But some of these may be ones where you're like, oh, okay, well, I guess I hadn't thought of that in my role. but it's just important that someone is, right? So who in your organization is managing the referral relationships in both directions? When we refer out, when we hire vendors, when people refer to us, we're humans and like we want to get business, and not just business, we want to help people. And we need to keep our beds full so that we can pay our staff. Like all those are not bad things. We just need to make sure that the way that we arrange our relationships doesn't have anything to do with like paying referral fees or paying above fair market value. So like this just needs to be on someone's radar and there need to be controls in place. Here are just some examples. We won't read them, but like here are some specific high-risk situations that the guidance talks about that you may be like, oh, okay, how we're arranging our medical directorships. People can get a whole lot of trouble with medical directorships, especially if they're a referral source, right? Hospital arrangements relating accepting patients or reserving beds, the way we interact with our hospice organizations. It may not have been something that you thought of, but like it's definitely one. And you know, Alyssa, maybe it's something for us to think about on a future discussion. Like this is probably not something, these areas are not something that are as familiar with the majority of folks in leadership positions in nursing facilities. So it may be something, you know, to consider further conversation on. Some other risk areas. I think the first one kind of makes me smile because every skilled nursing organization that I've worked with does have family ownership. Like my favorite was when every single person on the board had the same last name when I was presenting to them about their compliance risks. That's really common in this space and it's not in others. Like you don't really see that as much in hospitals or whatever, like nursing facilities. Now I know we have a lot of venture capital and private equity now, but we still have a lot of families. Not a bad thing, it's a good thing, but we have to make sure that those financial transactions related to people who we're related to have a business need and that they're fair market value, and compliance should be working with finance to audit and monitor those. And that way you can provide documentation and say, hey, yes, there's a relationship and there's money being exchanged, but we've looked at it and here's why it's okay. That's very significant when you can say we looked at it and here's why it's okay, and it really is okay. We talked about Stark Law. Anti-supplementation is that whatever the agreed upon payments from Medicare or Medicaid from the patient, you can't ask for more than that from the patient. The guidance goes into more detail there. HIPAA privacy and security, that's a whole other conversation. We could have that one too. We could have all kinds of interesting discussions on HIPAA privacy and security in the nursing facility space. I don't know what else to say there. That's a whole other conversation, but obviously we know what we need to do to keep patients' privacy rights intact. And then our patient civil rights. If you're not familiar, we talked about HHS, Health and Human Services, OIG. HHS OCR, Office of Civil Rights, is the organization that oversees HIPAA, privacy and security, as well as other civil rights laws like anti-discrimination and things. So if you're interested in these things, it's good to look at those websites just to kind of see what they have. So the guidance also has some other compliance, quality, and resident safety considerations. I mentioned that the general guidance really has the structure that we need to have in place around a compliance program, but the ICPG does have some specific implications around oversight, experience of the compliance officer, the role of the compliance committee, and I like to your question earlier, Alyssa, it specifically talks about supporting collaboration and alignment between compliance and quality functions. There is a lot of overlap. Now, what you need to make sure, I've worked with some organizations where everything the compliance committee was doing was just quality. They weren't thinking about these other fraud, waste, and abuse risks. So it's really just a matter of making sure that the risks that are included kind of in the purview of the group include everything, not just like the ones that we know best. It talks about competency-based training. It talks about risk assessment and internal review and monitoring processes, as well as reporting requirements. So, you know, maybe now that we've had this discussion, if you haven't read the general compliance program guidance in the industry specific for nursing facilities, maybe now kind of when you read it, it'll give a little bit more flavor because we've had this conversation. And they're not boring reads. I mean, I can say that. They're very well written. When the general compliance program guidance came out, I think it's like 94 pages. I was on an airplane. I shouldn't say that. I wasn't on an airplane when it came out. It came out, I printed it and took it with me on a plane to read, kind of dreading the 94 pages. But I was like, oh my gosh, they did a great job. One of the OIG monitors that is the assigned monitor for one of my clients' corporate integrity agreements was one of the main authors. It's really good. They did a great job with these, so they're not boring to read. They're interesting. If you look at the 2000 and the 2008, they were always published in the Federal Register. And if you know what that means, it's what the requirements of participation look like in columns, and it looks like newspaper, and it's tiny print, and it's awful. OIG is like getting with the program. They want to have an updated look. They want usable materials. So like these are fresh. They link to other guidance. They're going to keep them updated. So good job, government, for like trying to help us find what we need a little bit easier. I mentioned that there's also a link within the nursing facility ICPG, another supplement. It's called a reimbursement overview. So I have the link here for you, and I just took a screenshot of the table of contents. If you're like, hey, I think that might be helpful, this is what they talk about in that supplement. It's only 12 pages, but it just gives kind of a little bit deeper dive on reimbursement when it comes to compliance risks. So if this is something that pertains to your roles and responsibilities, it might be something to just take a peek at. Okay, so I mentioned this concept of checking the box, right? Because when I think of a surveyor, forgive me, those of you on the call who have been or are surveyors, literally there's like a checklist, right? Like you're going in and you're making sure that they've done all these things, and there's dozens and hundreds of things to check the box. On a compliance program, just because you can check the box, do they have a code of conduct? Yep. Do they have policies and procedures? Yep. Does their compliance committee meet? Yep. Does that mean it's effective? Because remember at the outset, the expectation from the federal sentencing guidelines, which is where all this comes from, Chapter 8 of the federal sentencing guidelines is the birth of compliance for all industries. A compliance program that effectively prevents and detects fraud, waste, and abuse is the standard. So just because, this is my challenge for you, just because you can check the box because you have something in place. So did that gentleman with the binder, right? He could have said, I have policies, they're in a binder, but like, were those policies doing anything? Did they have legs on them? And were they actually helping the organization to prevent and detect fraud, waste, and abuse relative to these risk areas? So that's another kind of takeaway to think about. A compliance program can't be perfect. Like one of the things that I do in my role as a compliance consultant, I do a ton of compliance program effectiveness assessments. So literally I go in and I'm not checking to see if they have these things. I'm checking to see if they're working. So I'm interviewing people. I'm doing all these things, and I tell every client at the outset, just know in the end, I'm not going to say your compliance program is effective because nobody has arrived. There is no pot at the end of the compliance rainbow. We can always keep getting better, but that's part of even showing effectiveness. If we're always evaluating ourselves and keeping our compliance programs evolving to be more in line with our risk profile, that's what we need to be doing. So, I did write an article for the Healthcare Compliance Association a few years ago that is linked here. And Alyssa, I don't know if we need to change what the links look like in the PDF to like make them clickable, but whatever we need to do. It's from my website, and you can read the whole text with this link. If you go to HCCA, you have to log in to read like more than a paragraph, but it's how to know if your compliance program is effective and just some concepts there. So if you think that's helpful for weekend reading, wonderful. I mentioned risk assessments. We have to know what our risks are to know how to prevent and detect them, right? So the ICPG gives us a lot of those risk areas. Those are the slides that we were just looking at around quality of care and anti-kickback and billing issues. But we need to understand what our risks are. It's a best practice to work with other leaders in your organization. It should not be done in a silo. Get everybody's input. What are our risks? What are they from a prioritization perspective? What are our top 10 that we need to be doing something about? That's a whole other conversation. I've linked an article here also from the Healthcare Compliance Association that I wrote around risk assessments. It's kind of a 101. If you're like, hey, would love to know more, just another free resource there. So where should you go from here? I kind of hope, because I am a compliance nerd, that something about our conversation you found interesting and you're not like, oh, compliance is not as boring and terrible as I've always thought it was. It's kind of cool. It does help us engage our teams. It does help us protect our patients. It does protect our reimbursement. It does protect our reputation, and it does keep us literally out of prison, because yes, people do go to prison for fraud, waste, and abuse. If you are like, you know what, I kind of like this stuff, check out the links that are in this deck. I know Alyssa posted some of them in the chat. And like, get some further compliance training. There are actually certifications. If you saw the certification, the letters after my RN, CHC, CHRC, CHPC are certified in healthcare compliance, certified in healthcare privacy compliance, certified in healthcare research compliance. If you're like, I love this, I like the idea of getting further training here, HCCA, like I mentioned, the Healthcare Compliance Association, it's where all of us compliance nerds hang out. We get together once a year at a compliance institute. This year it's in Vegas. Would love to see you there. If you end up going, send me an email. But also ACA, Leading Age, other organizations have specific compliance training that's more less general and more specific to nursing facilities. So like if you're interested, learn some more. It's great. Connect with me on LinkedIn, reach to Alyssa, like would love to just jump on a call with you and talk about it if you have more interest, because I think it's great. I've spent the last 15 years helping people develop and have good compliance programs. Find network contacts. Sometimes compliance people can feel like unicorns. There are very few of us. So if you're interested in this, like start finding people on LinkedIn or at conferences who are interested as well, and just connect with them and, have coffee with people, etc. And then you see that it's kind of a small world. That's the nice thing about being a unicorn. I mean, I think there's only 12,000 members of HCCA. So like in theory, of all the millions of people in the United States, 12,000 of them are healthcare compliance people. It's not really very many. Find a mentor, find a partner. If you want to grow in this, find somebody who's been doing it for a long time and ask if you can just get to know them. And then if there's things that we talked about today that you're like, I think we may have some issues at our organization. I don't think we have an effective compliance program. There's a lot of great people out there that can help you, both generally, and there are organizations that are specific to long-term care. So seek some input, get someone in to assess your program and help it become more effective. Or, if you don't have enough staff, you can hire somebody for 5 hours a week just to help do all the things. But in the world of compliance, it's not really a good one to put under a rock and pretend it's not there. It's a good one to kind of get out ahead of, and if there are issues, get those addressed. So like I mentioned, I threw my email here. I work closely with Constellation, so my Constellation email address is here, as is Alyssa's, and I know you know her well. This has been great. I know we have just a couple more minutes, so if there's any other discussion or questions, that would be great.
It's a really great overview, Sarah. Thank you so much. And all those links were terrific.
Great, thank you.
It was, Sarah. This is Lisa Rivas. This was very, very helpful, and I'm looking forward to the link. So thank you so much.
Great, thanks, Lisa.
Mhm.
There were pieces that you were talking about, Sarah, that I guess we don't always necessarily, I never really thought about how we were bringing corporate compliance into some of the work that we were doing that's, beneficial for a lot of our new peers and colleagues coming into the industry are trying to link them up. Like, if we got cited on a survey for an allegation of not providing a treatment, ensuring that or medication, that we remove those bills from that we're not submitting them to Medicare to be paid for, and tying that loop back together. That is an important component, but it's not really in the regs. It's just things that we know to do and how it links back into that compliance program.
Yep. And I think there are some compliance officers out there who are like really siloed, and unfortunately the like dinosaur version of compliance officer was like someone nobody liked. They said no all the time. They were trying to get people in trouble. Like, I'm certainly not like that. The people that I know in this industry are not like that, but unfortunately that can be the reputation. So in organizations where people perceive the compliance officer as like someone like that, they don't want to involve them, right? So it silos compliance, where really compliance should be very collaborative, should be at the table for a lot of these things to like identify and provide guidance. So I think that's another component as well. Just invite compliance to the conversation. If you're like, I don't even know who our compliance officer is, send them an email. Like, ask to have a virtual coffee chat with them and ask them what they're doing and tell them that you've learned a little bit more about it and you'd like to know more. Like, that's a really good, practical step to help you tie your practice even more closely to compliance and making sure everyone's on the same page.
Do we have any more questions from anybody on our call today?
Tara, I'm not sure if this correlates. I think it is a little bit there with the new rule related to section 1557 and the 504 compliance coordinator. Are you seeing in the industry where there is a corporate level and then into each area has their own with that expansion of that 1557 versus just the 504 compliance coordinator?
So I'm not a detailed expert on that, but I feel like with a couple things. So making sure that that risk is part of your risk assessment. We talked about like making sure that compliance and like in whether it's compliance and QAPI, like, is this on the radar? Are people talking about it? And I think in general, Patricia, having a corporate approach that then everyone implements themselves as opposed to the Wild West and everybody's responsible for separate implementation. I tend to think that having one consensus approach that everyone is doing is the way to do it. But I apologize, I'm not an expert on either of those in particular.
Thank you.
Sure, thank you.
Great question. Great question. Well, we're coming up to the top of the hour. Thank you, everybody, for joining this amazing session as our first kickoff in 2025. As noted, we've got several more sessions already booked in. I would love for you to join us in February, where we have a gentleman that is doing work and research of the benefits of sleep and how we can tie that into our compliance with the new guidance or continued focus on reducing the use of pharmaceuticals as we care for our residents. So seems like this would be appropriate and timely. In March, we're excited to be hosting a panel discussion on technology and considerations in implementing technology such as AI or some of the more engaging technologies available between our residents, our families, our staff. If you have questions about that you'd like to have and pose to the technology committee, please send those on over to myself or Olivia Smith. We'll make sure that we have those included into the panel discussion. And I'm blanking on April's session, but more to come on that. The first quarter is starting off great. Thank you again, Sarah, for joining today. We will share all the resources to everybody that's been registered for our call, so you have them available to you. If you're watching the YouTube channel and you want to get more information, feel free to email us to learn more about corporate compliance, or as well as joining our series. We're happy to have you, and we'll get those materials over to you as well. Any parting words, Sarah?
No, thank you very much. Appreciate the invitation, appreciated the conversation, and I think everyone asked great questions. So thank you for being involved.
The future sessions, will we use the same link that we got onto this presentation, or we'll have to register each month? And then the April one is expert strategies for enhanced resident care presented by Teepa Snow.
Yes, how can I forget Teepa? Goodness. Let's not tell. Thank you, Patricia. Yes, that's the registration link is for the entire year series. So you should be able to log in, and then that will be the link that we send out the updates for the slides. So if you happen to have state visitors come in on a day that we have a quality leader session, you can still watch the recording on our YouTube channel, and you'll have the material sent to you via that registration, that email that you've shared. If you do share your login with any other team members that they're coming on in your organizations, you'll be the one that would get the links for the materials. You'll just want to share those with them. and anyone else is welcome to join us. So feel free to share this quality leader session with everybody. We're happy to have them on the call.
Thank you so much.
Thank you, and have a fantastic day, everybody. Thank you so much.
Thanks, bye.
Bye.